session. The first lecture will be presented by Professor SEUNG KIM. Professor Song is Professor Emeritus at Seoul National University Hospital, consulting professor at EUMC, Director K Radiology Clinic. The title of his topic is Imaging Characterization of Small Renal Masses. Thank
you. Thank you for your kind introduction. And it is really my pleasure to be invited to this beautiful country, beautiful place. And as Chairman introduced, I'm from Seoul, Korea, and I specialized in urogenital imaging for more than 30 years. And in 2019, I retired from a government university hospitals, and now I'm running my private nephrology clinic. Also, I work as a consulting professor at one private university hospital, having the urology hospital. So in this time, I would like to share my experience of imaging characterization of small renal masses. In our daily practice, with ultrasound or CT, often we encounter many cases of the indeterminate small renal masses. So that imaging of small renal masses are often problematic because they are too small, and because we have a difficulty in differentiating between true and pseudomass, and differentiating between solid and cystic mass, between neoplastic and non-neoplastic masses, and between benign and malignant masses. So I would like to talk in this sequence. The problem one, when the masses are too small to characterize, we have a problem like in this patient. Here is a here's a mass kidney in the posterior portion right here, and in early phase looks like a little bit enhancement there, and in this late phase the mass is here. So it is not easy to determine whether there is a real enhancement or not. In this coronal images, early phase, late phase, also it's difficult to distinguish between true and pseudo enhancement. So true mass, true tumor, or pseudomass. In those cases, we do not need to hurry up too much. In this patient, followed up with the surveillance, 4 years later, this mass becomes smaller, and this patient is still on follow-up, and mass decreases in size. So without operation, this patient was followed. So when masses are too small to characterize, do not hurry up. Follow-up and the surveillance are often useful enough. Here's another similar patient. Mass is here, and looks like a little bit enhancement here. And we should be careful because if this is a true enhancement, this mass may be a true neoplastic mass, and this patient was also followed up, and this is 5 years later, this mass becomes bigger. Now there's a clear enhancement so it's a true renal cell carcinoma, and it was a clear cell type renal cell carcinoma in this patient. So starting with a similar, very small mass, but story is very different in those two cases. Sometimes the mass looks like here, but margin is not very clear. And in these patients, maybe we can get help from other imagings. Nowadays, if we have a mass like this one, probably we may ask the MRI. And in this patient, mass is here, and T2 weighted images. Here's the mass, here's the mass. The signal intensity on this T2 weighted images, the signal is not low, it's quite high inside. And also in this patient, peripherally, there is a low signal intensity rim. This finding is very important. If there is a low signal intensity rim, it means the pseudocapsule. This pseudocapsule means the mass has an expansile growth and pushing the surrounding parenchyma. So it means that it is probably a malignant mass. And this patient, the mass was turned out to be a clear cell renal cell carcinoma. So in this patient, mass is very small again, but not too small to characterize. We can characterize this mass with help of MRI, and the MRI finding clearly suggests this malignant mass. The problem 2, the distinction between true mass and pseudomass. The most common pseudomass we encounter in our daily practice at ultrasound is the prominent column of Burton, so-called prominent column of Burton, invagination of renal cortical tissue into the hilar area. Normally, this is a normal column of Burton, and if that invaginated cortical tissue is prominent, we call it prominent column of Burton. There are two masses at ultrasound, similar size, similar location, similar echogenicity. One is true mass, the other one is a false mass. It is not easy to distinguish which one is which, and with grayscale. If we do Doppler ultrasound, probably it's easier than with only grayscale ultrasound. In this patient mass, there is a vessels, many vessels running through this mass like lesions, and in this patient, in this mass, the vessels are swept around this mass-like lesion, so you may easily get information. The probably upper one is probably a pseudomass, and the lower one is probably a true mass, and you can confirm that with CT scan. Upper mass is clearly a prominent column of Burton, and the lower mass is a renal cell carcinoma. So in this case, the color Doppler ultrasound was very helpful, showing the vessels, relation of the vessels with these mass-like lesions, passing through the lesion or sweep around the lesion. Here are 3 different masses on the kidney at ultrasound, and this color Doppler ultrasound shows similar findings of the vessels passing through these lesions, and all these 3 mass-like lesions are not true mass, but it's a pseudomass, so-called prominent column of Burton. Sometimes we have a difficulty in distinguishing the lesion in renal sinus area, like these 3 patients, the upper one here, middle one here, and the lower one here. And somewhat hypoechoic, low echogenicity mass with the Doppler ultrasound shows some mottled vascularity in here in the first case, and then the second patient's a little bit vessels around the mass-like lesions, and in third cases there is a scanty vessels inside. It's not easy to distinguish the cause of these hypoechoic areas. The first one was actually urothelial carcinoma in the renal pelvis area, and the second one was the renal cell carcinoma bulging into the renal hilar area. It was a chromopop type of renal cell carcinoma, and the third one, there was nothing on CT scan, it was a prominent column of bulging into the hilar area. So when you see something suspicious in the renal hilar area, you need to be careful, and usually you need a CT scan to confirm the cause of these abnormal findings. The problem 3, we are characterizing small renal masses is distinguishing solid mass from cystic masses. As CT scan, sometimes it is not easy, like this case. Non-enhanced, early phase, late phase, and the masses here. Looks like there is some enhancement in naked eye, but naked eye is not always correct, so you need to measure the Hounsfield unit with the machine, and 9.5, 15.1, and 27 in these 3 sequential CT images. It is not easy to distinguish true enhancement or so-called pseudo-enhancement. When the enhancement, the degree is less than 10, usually it is insignificant, and higher than 20, usually we think it's a significant enhancement, and in between it's equivocal, like this patient. In this patient, enhancement is a little bit less than 20. And in this patient, this is ultrasound. Often ultrasound is more useful or more accurate in characterizing this, distinguishing this solid and cystic mass. And ultrasound is clear that it has a round shape and sharp margin, no echogenicity, and posterior sonic enhancement, no vessels inside. So with ultrasound, it's easy to make a simple cyst, but with CT, it's not easy to distinguish. How about this mass? This is a Hounsfield unit. The enhancement is not definite. And here is the mass. And at ultrasound, the mass does not have a typical appearance of the simple cyst. If we have a problem like this case, maybe we can do MRI, or another thing we can do is contrast-enhanced ultrasound easily. And in this patient, contrast-enhanced ultrasound was done, and there is no contrast enhancement at all, so we can make a diagnosis of the cyst, simple cyst without enhancement. Problem 4, sometimes we have a difficulty in distinguishing neoplastic versus non-neoplastic masses like this patient. Here's a mass-like lesions in this right kidney and having some scar, indentation here, and the low attenuated areas here in the right kidney. And it's not easy to characterize this mass, but in this patient, the mass was taken out, and the pathology showed that it's just a chronic inflammation around the scar, and there was no mass. It's not easy to distinguish between neoplastic and non-neoplastic masses. How about this one? It's a similar, ill-defined, low attenuated area here. Ultrasound does not show the mass clearly, so it's not easy again. And in this patient, follow-up was done, and after 2 months, the lesion disappeared. In many cases as CTA, and in a certain phase of enhancement, because the medulla enhances the later than cortex in some phase of scan. So medulla has unusual low attenuation, may mimic a mass like this one. So if there is a question regarding a neoplastic or non-neoplastic lesion at CT scan, the good way is to follow like this patient. So wait and see is the best way in many cases like this patient. Similar ill-defined low attenuated area here. So maybe we can follow up. And 2 years later, now it's clearly renal cell carcinoma. So if we can wait and see, but we need to be careful, and we need the careful surveillance. Now, next problem, And probably a most common problem we are facing is a distinguishing benign from malignant neoplasms. We can divide that into two scenarios. One are cystic, mainly cystic lesions, and the other mainly solid lesions. So with mainly cystic lesions, when we are distinguishing benign from malignant renal lesions, we use famous Bosniak classification. This is Dr. Bosniak, passed away 2016. And he developed this Bosniak classification system in 1986. And there was many updates with this classification system. And the last update was in 2019 by Dr. Stuart Silverman. And we categorize in the 5 categories, 1, 2, 2F, 3, and 4, these categories. And this is original Bosniak's classification. And in this talk, I do not go into the detail of these descriptions, but one is usually it's a simple cyst, and we do not need nothing is necessary. And 2 is just minimally complicated, and also we do not need for the thing, or we do not need follow-up. 2F is a little bit more than 2, and a little bit thicker septum, or a little bit calcification, a little bit higher attenuation. So we need a follow-up. Imaging is category 2F, and 3 is more than 2F, and the chance of malignancy is half and half. So usually we need a surgical treatment, and the class 4 is almost the 100% malignancy, so we need surgery. So that is a basic 5 categories Bosniak classification system. And this is the last update in 2019 by Dr. Silverman, and he introduced the MRI finding here, and he described more detail of the thickness of the septum, but basically same. The important thing is a risk of malignancy. As I said, the category 1, no risk of malignancy. Category 4, 100% risk of malignancy. Category 2 is almost 0%, so we do not need follow-up. Category 2F, we need follow-up because there is some chance of malignancy. A lot of people reported different chance of malignancy, but usually it is less than 5% in 2F. And 3 is almost 50%, half and half chance of malignancy. So always we keep in mind that risk of malignancy, and always that keep in mind that when we are communicating with our counterpart urologist. Here's a very nice paper in 2019-17, meta-analysis of the risk of malignancy. As I mentioned, this is a category 4, Bosniak 4, 100% risk of malignancy, and 1, 2, and the 2F is the close to 0%. 2F is around 5%, and Bosniak 3 is around 50%. Among the cystic renal masses, the mass sometimes have a so-called multilocular cystic appearance. When we see multilocular cystic appearance, we need to have a list of the tumor category in our mind, and most important 2 disease in malignant category is a cystic renal cell carcinoma. That is mostly clear cell type. That is the most common scenario of this multilocular cystic renal mass. And the second thing belonging to the malignant category has a long name, so-called multilocular cystic neoplasm of low malignant potential, MLCN, LMP. It's a long name. So formally, it is called multilocular cystic RCC, but now the official name is multilocular cystic neoplasm of low malignant potential. So think about those 2 categories, malignant categories. And benign 2 categories are cystic nephroma and mixed epithelial and stromal tumors. So when you see this kind of multilocular cystic mass, think about those two malignant categories and two benign categories. The first thing, this one, multilocular cystic appearance, very complicated septa, irregular, and some area forming the solid portion like, and this is a gross pathology. This is a malignant lesion, and this is a clear cell renal cell carcinoma. And the second and third, the mass is here, and having complex septa, but not very thick, a little bit irregular. And third one also has a similar complicated septa, not very thick, but irregular. When you encounter that multilocular cystic mass with somewhat irregular, but not very thick, and without solid nodule, you think about that long-named tumor. As I said, multilocular cystic neoplasm of low malignant potential. In this tumor, tumor cells do not form a solid nodule. The tumor cells are spread along this complicated septa. So when you see this kind of septa, you think about that multilocular cystic neoplasm of low malignant potential. And two benign categories, examples are here. In upper one, as the mass has a abundant septa, quite thick, but probably you feel that the septa is not irregular. It's quite smooth, thick septa. Also the peripheral margin, peripheral capsule is well formed. When you see that kind of mass, you think about benign category. And the second mass also had a very thick but smooth septa. The first one was cystic nephroma. It's also called multilocular cystic nephroma. The second one was mixed epithelial and the stromal tumor. So when you see this kind of thick, smooth septa, multilocular cystic mass, think about those two benign categories. So I'll say septal irregularity is much more important than septal thickness in distinguishing benign and malignant in this multilocular cystic mass. Now, think about the solid mass differentiation between benign and malignant. This is an old report, but very important report, reporting that many of these small renal masses are benign. About 20% of removed small renal masses are benign. And about 60% are indolent cancer, and only 20% is potentially aggressive tumor. It means that if the mass is small, so we do not need to hurry up. Maybe the mass is maybe benign or just indolent cancer. So among the benign tumors we often remove, is the most common thing is a angiomyolipoma, especially fat-poor angiomyolipoma. That is the most common problem when we are seeing the solid mass and differentiation between benign and malignant. The most common tumor is the fat-poor angiomyolipoma. The second one is a small oncocytoma. Of course, there are other rare benign tumors, but those two tumors, fat-poor angiomyolipoma and oncocytoma, are two most common benign tumors removed because we thought about the possibility of malignancy. First, fat-poor angiomyolipoma versus renal cell carcinoma. There have been a lot of papers in focusing on this differentiation, but this issue is still going on. We did not solve that problem perfectly. Now, the most useful parameter we can use is the MRI findings, T2-weighted MRI. If the signal intensity of that mass at T2-weighted MRI is low, we'd better think about the possibility of benign fat-poor angiomyolipoma, like this one. Here's a slightly hyperechoic mass and slightly enhancing mass in the right kidney, and MRI show the low signal intensity at T2-weighted images, and in this patient biopsy revealed fat-poor angiomyolipoma. So this is the algorithm we can use. And if there is a problem in differentiating between renal cell carcinoma and fat poor angiomyolipoma, and then we do MRI and look at the T2-weighted signal. It has a low signal intensity. The possibility is more like a fat poor angiomyolipoma. And if it has a high signal, and in this case, do not do surgery, but biopsy or surveillance is enough. If it has a high signal intensity like this one, and think about the renal cell carcinoma, especially clear cell type renal cell carcinoma, and do surgery. That is the basic algorithm. These are two fat poor MRI cases, and similar findings as CT, and similarly T2-weighted MRI shows low signal intensity. So this basis were fat poor the angiomyolipomas. But we should keep in mind that some renal cell carcinoma, especially papillary renal cell carcinoma, can show similar findings, low signal intensity at T2-weighted images. On those left-sided two masses have a low signal intensity at T2-weighted images, papillary renal cell carcinomas, and this right side was even chromophobe type renal cell carcinoma may show similar low signal intensity. The shape is also important. If the mass has like this shape, ice cream cone or mushroom shape, it means that inside the kidney, it has a somewhat triangular shape, and outside the kidney, if it has an expansion like this, so making this shape, think about a very soft mass, and more likely a fat poor angiomyolipoma than renal cell carcinoma. Those two cases are all fat poor angiomyolipomas. How about this one? Let's say there is a mass here, and here's the mass. If you look at the mass carefully at ultrasound, you can see hypoechoic rim around the mass. And in this early phase CT, you can see low attenuated peripheral rim. These findings also indicate pseudocapsule, and this finding indicates that the more possibility of malignancy, and this was a clear cell renal cell carcinoma. So the finding of pseudocapsule is important again in this patient. The last thing I would like to mention is regarding the CT findings of oncocytoma. My colleagues, my junior colleagues in the Seoul National University Hospital did a, is it timeout? So I'll hurry up. And so-called segmental enhancement inversion. Like this bottom two images, early phases, there are the strong enhancement area and the low enhancement area, and the late phase, the relation is inversed. This finding was we call the segmental enhancement inversion. If the mass shows this finding, it suggests the possibility of oncocytoma. Another similar mass showing so-called segmental enhancement inversion, and the reason is because the different areas, some areas compact tumor cells, and the other areas has a loose tumor cells. That's why it shows the inversion of enhancement. And after we published that paper, a lot of people show that, oh, this finding is not always true, and many cases showing this the mass was not oncocytoma, and our team continues to report that it's true if the mass is small. If it is not, it is usually not true if the mass is large. So there was one systematic review showing that it has a high specificity, but sensitivity is different. High sensitivity if the mass is small, and low sensitivity if the mass is large. So in this talk, I shared my experience of deep problems in imaging characterization of small renal masses. Usually, the problem is the mass is too small. We have a difficulty true versus pseudo, solid versus cystic, neoplastic versus non-neoplastic. and benign versus malignant. We usually solve that problem with imaging, ultrasound, CT, MRI. Thank you very much for your kind attention.
Thank you, Professor Kim, for the excellent presentation. Now we'll move for the next speaker, Professor